Thank you for joining us. For the past 15 years, I've been working at Canada's International Development Research Centre, IDRC, mostly with the Maternal and Child Health Program. And in this capacity, I've had the privilege of supporting interdisciplinary global health research, much of which is implementation research. And last spring, Canada launched its first feminist international assistance policy. And this policy is interesting because it provides a strong framing and additional support for IDRC to continue supporting research that foregrounds issues of rights, equity, gender equality, and justice. And you'll notice that this session does indeed focus on gender. And I just wanted to make a small note on how we are going to be using the term gender on this panel, with the recognition that women and girls continue to have limited access to rights, opportunities, and services around the world. Discussions about gender this morning will transcend these binary boundaries of women and men to include other social markers such as class, ethnicity, nationality, ability, religion, and sexual orientation. I thought it was important to set this tone right from the outset because as a global health community, I think it's really important for us to continue to fight against this narrow binary of just interpreting gender as being only about men and women. Now back to the conference. This conference is titled Innovative Approaches to Global Health Challenges in LMICs. Now, the term innovation, I'm sure, conjures up a lot of different ideas in your mind. We've heard a lot of different manifestations of innovation yesterday. We heard some more this morning. Some people might think of innovations as a product or a technology. Other people might think of it as a social arrangement or a methodology. But I think we'll all agree that innovation is undeniably, it's grounded in the context within which it's used. So, and then one more thing is that it's also finite. So a global health innovation is finite, and like other finite resources, it's contested. So who can access them? Who decides? Who has the power to choose? And who designs these innovations? And ultimately, who benefits? And it's these types of questions that our speakers will be engaging with during this panel. And just to mention that they'll be sharing experiences from different cultural contexts and recognizing that the specificities of these cultures and social norms and gender relations is of paramount importance for us to discuss and understand and engage with, but they shouldn't be used as an excuse to discriminate against individuals or groups when they do attempt to access resources or exercise their power. So, with that as a backdrop for the panel, let me start by introducing our first speaker. And if you don't mind, what I'll do is I'll introduce each of the speakers before they speak, so that way you don't have to absorb all of their background information all at once. And of course, each of them have very long, impressive bios. I'm just going to do a very short one, so please excuse me for that. Our first speaker is Dr. Faisal El-Kak. Dr. El-Kak is a senior lecturer of health behavior and sexuality and public health at the Faculty of Health Sciences here at AUB. He's also a clinical associate of obstetrics, gynecology, and female sexual dysfunctions at the Department of Obstetrics and Gynecology at AUB's Medical Center. Dr. El-Kak will address gender dimensions of global health through the lens of adolescent youth-friendly health services. So.
Good morning, and thank you for being here, and thank you for inviting me to this esteemed conference. In my 10 or 11 minutes presentation, I will raise one question and argue it. The question is, does calling a youth service a friendly service make it friendly or unfriendly? And why is it friendly and why it's not friendly? In 1997, I was a fresh graduate from the training program for OB-GYN here at the American University Medical Center. And I went to Finland for a meeting on adolescent sexuality. part of the meeting is like they took us for a field visit. We went into something that looks like a mall with different functions inside the mall, people playing music, people drinking, eating, and then you have people sitting down and talking and everything. And then at that time, the president of the adolescent gynecology meeting, Professor Dan Apter, who's been to Lebanon several times, he said, do you know what is this? I said, this is a mall or this is something. He said, this is a youth-friendly center. And this is the #1 leading center in Europe. You will never feel you're entering into a youth center with a stigma or a label. You're discussing your private sexual needs or options or family planning, so on and so forth. So on that notion, a study of 70 centers, so 70 youth communities in almost low-middle income countries have reported that 10% or fewer of all adolescent women had visited a health facility, although it was available, in the past 12 months, and those 10% were informed about family planning options, only out of the whole group. Data from 41 countries show that 20 to 25% of married adolescents reported an unmet need for contraception. And this raises the issue of equity, which is the most pressing issue among this population. And you can see here this is very fancy. Healthy life expectancy, 15 to 29 years old by income by 2010. And you can see just by income the difference between life expectancy in those countries. Again, the mortality rate per 1,000 for adolescent and youth population. Okay, thank you. Is again, you can show the issue of inequity in mortality rate between low income and high income countries. The issue of having youth-friendly services and services for the youth and meeting the needs of the youth have started with the famous ICPD 1994 that coined officially the term of reproductive health and introduced sexual health as part of the overall services of reproductive health to the adolescent population. And that was emphasized, at least for our region, in the Cairo Declaration of 2013 in the revision of ICPD4, again emphasizing a rights-based approach, emphasizing meeting the needs of adolescents, and also emphasizing the importance of sexuality education as a service for this population. Again, of course, the confirmation by WHO in that regard. So with the rights-based and ability to meet the health needs, especially sexual reproductive health needs, and setting indicators, what exactly do we mean when we talk about adolescent youth-friendly services? Sometimes you can see AYFS or YFS. They have to be affordable in the sense that youth, males and females, can afford to use these services when they are available. And at the same time, they have to be equitable, allowing for gender equity, more females using these services. Access, of course, effectiveness of these services. Why effectiveness? Because you can see in the revision that I will discuss later, a lot of services are absent. A lot of items are absent from that package, and at the same time, they're acceptable depending on the cultural sensitivities of the communities. Based on several reviews, what do you mean when we say adolescent youth-friendly services? They should have unrestricted policies by allowing not only the classic binary gender that we know about, but also all the diverse population. They should address the needs with confidentiality and with no judgment. They should engage and strengthen the adolescent participation, foster community dialogue and involvement, coordinate with other services within the center or within the community, implement outreach activities beyond health facilities. With this definition in the background, these services, and there is a lot of services globally, and a lot of initiatives that call themselves friendly and youth-friendly, either they are partially assessed, or the evaluation was never done, or impact assessment also was not done. This is an example on 4 areas in Iraq, Lebanon, Egypt, and Morocco. There was an assessment for these 4 centers, looking at the services and at all the indicators, and it was found that there was controversial outcomes in the assessment of these 4 services available. One related to inequities, in the sense not only that a little percentage of both will go there, but females are the least utilizers. There was a basic rights issue. There was no rights framework that dictates utilization of these services. Unmet needs or demands, and also there was issues related to lack of training and sensitivity of the provider, in addition to the whole setting that provides the service. There was no known impact evaluation that have been conducted seriously across all the indicators that define what is a youth-friendly service. This is from the global perspective, a study reviewing youth-friendly services, and it has been found out of 115 indicators that you have to assess by the youth-friendly services, only 3 are being used. One related to access, one related to staff, and one related to privacy. All the other 112 were not even looked upon. Another paper published in The Lancet, again, how are we doing in relation to the youth-friendly services? It was shown like little evidence is available, since many of these initiatives have not been appropriately assessed. Appropriate controlled assessment of the effect of youth-friendly services models on young people's health outcomes should be the focus of the future research, which remain to be absent. This is a series of papers published in the Journal of Adolescent Health to look at revision of ICPD 94. It was published in 1994. And they have used 4 items for assessment of youth-friendly services. One is facility-based. The other one is out of the facility. Third one, intervention reaching vulnerable population, interventions to generate demand and or community acceptance. Again, there was absent or very few studies looking at assessment according to these 4 indicators. There was no actual assessment for the process itself, for the impact, and for the outcome. And youth centers are not an effective way to deliver sexual reproductive health services according to those reviews. So by calling it a youth center with all the items lacking, whether in the process or in the delivery or in the package content or in the outcome, youth centers are not really the way to deliver sexual and reproductive health services. So what kind of interventions all these papers and all these reviews have concluded? Well, you have to look at all this spectrum, okay? You can start whatever you want. Timing, the timing to start the service. You see, adolescent is a very critical but shorter period in the lifespan of the people. So many of the habits, many of the needs, many of the issues will arise early in the adolescence. So establishing a center for those who are 18 or 19 or 20 because of policy problems or legal age problems and stuff, it probably can be too late most of the time. You have to assess the needs of adolescent people in a specific community to make relevant deliveries. The context in which you have to provide the service, rights-based, complementary, integrated services, engaging with the community, participation of the adolescent population, participation of the young people in the making of the service, engaging the family and the community to start a dialogue. We did, for example, produce in our in the Faculty of Health Science, in the Youth Reproductive Sexual Health Project, 2 manuals. One is used by parents to answer to the question raised by their kids, and one for adolescents, again, to think of what kind of questions they can address to their parents. And that is really have been very fruitful, very beneficial in terms of engaging parents and also letting parents understand the importance of the role of such centers. Skills, a lot of skills you have to train. In Egypt, for example, 80% of those engaged providers engaged in youth-friendly centers have no clue of the friendliness, meaning have no clue of the needs of the, sometimes the young people will come into these centers and the provider, they have no clue what these young people are here for. Money, you have to, the government and the funders and everybody have to know that when they develop well-integrated youth-friendly centers, they are cutting costs and a lot of morbidity issues, morbidity problem, starting from teenage pregnancies, starting from skilled attendance, starting from mental health problems. A lot of cut can be done. And of course, the issue of the policy meaning, as Shaitali said in the introduction, including everybody, including all the diverse population, including vulnerable population, disabled population in that policy within, again, rights-based approach. According to WHO, one of the essential primary intervention is universal health coverage. That's essential, and that was emphasized last week in a Satana meeting of the primary health care, in addition to the 4S, they call it the 4S interventions. The first S is generating and utilizing strategic information on the status of the adolescent population. We don't have. Honestly, we don't have. The only data generated on adolescent sexuality is the data we generated at the Faculty of Health Sciences by the Youth Reproductive Sexual Health Project, which is funded by Ford Foundation, and thanks to Dr. Montasir Kamal, who is here in this room. The other intervention is about evidence-based policies that inform governments. The third one is scaling up of the services to integrate them within an overall service and to strengthen the relation with other sectors, whether health or social. The last slide, again, based on data and based on the outlook of the ICPD 94, these, I think, 4 recommendations we can deal with. The first one is improving youth friendliness of the facility by looking at the equity issue, which is a major thing, in the discussions, and engaging young people in designing their own services. The other one is to train and support health workers. I've been working with reproductive health since I was a medical student, and now you catch a health provider on the street, you ask them reproductive health, they'll tell you, this is about family planning. This is about getting pregnant. Since '94, why not? Ms. Karaki is here somewhere. Zillions of talks, zillions of meetings, zillions of sessions on reproductive health, and people tell you, is it about family planning? You can look at data from Egypt and from Lebanon mentioned in the Arab Development and Health Report 2016. Generating adolescent demand And that's the most important recurring recommendation from all the reviews. Generate the demand by the adolescent. You have to create demand by reaching out to them, asking them, okay, let them voice what they want. You generate demand. You have to design a service. You have to design a package that's demanded. Not a center that you see one young person every month. And also building community support for their service provision to adolescents. Engage the community, whatever, religious people, school teachers, all other actors, even politicians. Because the political commitment done by the Arab government, whether in '94, in the Cairo Declaration 2013, was never translated into an actual respect to implementing services that are really friendly to the adolescent, whether health service, social service, or comprehensive sexuality education service. And thank you very much.
Thank you very much, Dr. Faisal. And now I'm going to invite Dr. Usha George. Dr. Usha George is the South African Research Chair in Health Systems, Complexity and Social Change at the School of Public Health at the University of the Western Cape, and continues also at the Johns Hopkins School of Public Health as an adjunct professor. Dr. George has also been recently elected as the Chair of Health Systems Global. She will be presenting evidence on gender and human resources for health with a focus on innovations in inquiry and imagination.
Thank you very much, Chaitali, and inviting me to be part of this panel, as well as to AUB and the Global Health Institute. It's very exciting to be here. So I'm going to present a little bit something different. I think they've been talking, the first presenter talked about adolescents, a key vulnerable population. And he's already begun to talk about the providers. Who are the providers? How do they engage with adolescents? And that's really going to be the heart of my presentation. So I'm going to present results from a systematic review that I am undertaking from work that I've done before, but also some reflections on what have we learned in this area. And therefore, since the conference is about innovations, what I'm going to argue is that there is a lot of data, and Dr. Suka presented these fabulous graphs of the associations, and several of them touched about health workers. But I'm going to argue that in this area, we really need innovations in how we think about health workers, who they are and what their role is. We need to shift our imagination as to who they are and the kind of research that we undertake as well. And that means changing how we're engaged in the field. So a little bit of background. As I said, I am revisiting a systematic review I undertook in 2007 for the WHO Social Determinants of Health Commission, and it was published in Global Public Health. And we're looking at, in the past 10 years, what have we learned since that initial systematic review, looking at gender and human resources for health. What's striking is that there's so much, let me just, there's, as a previous presenter described systematic reviews as a honing down. You have huge amounts of articles, and then you hone down to what's your focus. There are, talking about global health, there are divides, not just in the digital divide, but when we look at articles in the low and middle income country context, only 15% of the articles really looked at gender and human resources for health. There's much more investment in this area in high-income countries, and so part of this research is to call out for more work that needs to be done. So I'm going to present 3 slides just highlighting some of the key findings. One is that there is more research looking at the gender distribution in the healthcare sector. Now, this isn't a new finding. There were some very good graphs in the WHO report on health workers early in the early 2000s that really described how skewed the health sector is. That it's predominantly employs women, but women at the lower levels of your cadres, women who are often at the front line of service provision, community health workers, nurses, associate health workers. And there's, since then, I think now there's a lot of advocacy pushing for that awareness, but it's not a new statistic. A lot of our categories hide who we're talking about. So in terms of community health worker, it has no gender, but when you look at below, it's often women who are in those community level positions. So here are a few articles that revisit that, and there's one more recent article also from Oman that does a more systematic disaggregation. And what they show, for instance, here in Tanzania, as I said, when you look at assistants, nurses, midwives, they're primarily female. When you switch to medical officers and clinical officers, the gender balance switches. And same in India, particularly in rural areas. Not only are there fewer female doctors, but when you go to areas where there's a lot of need, that percentage decreases further. But these statistics also hide a lot of things. And in a lot of these health workforce statistics, they don't even count, for instance, ASHAs, which are the community health worker cadre in India, and the Anganwadi workers, who are the health nutrition workers at every village. If they counted them, the estimates would increase by 80% in terms of the role of women in the healthcare workforce. The key thing here is this isn't new, but we're only still doing basic crosstabs, and we could be doing more with that data to really look at what are the gender disparities in promotion, pay, job benefits. We're only still just disaggregating who is a health worker, and we could do much more. There's some, in the review we found further work on discrimination, and there's been a host of, the topic of, there's been a lot of research recently on disrespect and abuse by providers against women when seeking healthcare, but there's also been recent research on violence against and gendered violence against health workers themselves. And so what I've presented here on the left is some studies in Rwanda where people have tried to look at workplace violence and the gendered origins of that. Other research that looks more at an aggregate level found no consistent pattern. My finding from this is that we're only beginning to learn how to measure discrimination. Once you go beyond crosstabs of men and women, understanding how we measure discrimination in the health workforce is a conceptual and methodological challenge, and that really shows at some of the mixed results in this area. There's a lot of work in feminist studies that, as Chaitali says, goes beyond looking at men and women. And this concept of intersectionality, which looks at how gender intersects with class, race, how we really are looking at systems of power and how do they affect the populations we care about. Despite these advances in feminist methodology, there's very little applied to this area. We only found 2 articles talking about this. And one is from the Caribbean that really looks at gender and migration. There are huge amounts of health workers who have migrated, but there is very little analysis by gender and race about that. Let me go back. And this is one good example of looking at the structural drivers that underpin nurse migration, looking at it by gender and race and marital status. There's one article from Lebanon that really looked at how does the micro experience of being a health worker, how is that influenced by the organizational context and then the broader policy context. There's a lot more work that could be done in this area. I have 2 sort of reflections, and then I'm going to go to present some work we're doing in South Africa. So there are, even with the studies I'm presenting, there are big assumptions in this area. And although it's great to have advocacy to pay attention to gender dynamics in the health workforce, there are some huge assumptions and gaps. So often you hear that all community health workers are female, where actually we don't have the data sets that consistently track and disaggregate that. Are all nursing profiles female? Not necessarily, if you look at different country contexts. Are more female professionals migrating than males? we actually don't know that. So there's a lot more we could do with collecting good health labor force data and disaggregating it better. But we also need to move beyond descriptive research. And this is a reader I edited last year with WHO on really improving the quality of research in human resources for health. And what we found is there's lots of descriptive research in this area, but we need to go beyond sort of, our first presenter said, talking about impact evaluations, but also really, I think in this area, engaging with qualitative research can tell us a lot. So I want to present some work that I'm really proud that I can now do because I'm based in South Africa. This is work being led by one of my doctoral students, who's a medical doctor who's been based working with the health department for many years, and she's become, from a medical doctor, a filmmaker, and now engaging in health policy and systems research. So sometimes some of us have many careers all in one. This is the context of Cape Town. Many of you will know Cape Town as an incredibly beautiful city. It's also a city, and South Africa is one of the most unequal countries in the world now. So there are neighborhoods where every car is almost a Range Rover, a Jaguar, and a Porsche, and then 15, 20 minutes you drive in another direction, and it's a completely different reality. And the history of apartheid is still there, very much so, in the populations that were displaced, forcibly removed from certain areas, moved to other areas, the levels of unemployment, gang violence, the problems that certain communities face that are living right next door to each other. So in these areas, a lot of where historically people were moved to the Cape Flats, there is now so much violence that there are attacks on health workers entering those areas as well. And they have created red zones in these neighborhoods. And that means for a paramedic, for an ambulance to arrive in those neighborhoods, they need a police escort. This entails added delays, and in some cases increases the level of risk because those gangs also want the weapons that the police are bringing in. So it really pushed the health department to think, what can we do in this situation? Clearly the policy of creating red zones led to its own unintended consequences of restricting access. So she has been she's been engaged with paramedics for a long time. She's developed this short film that has been screened in multiple places, but we use the film to also do community screenings, to bring communities together. I was just so struck in the community hall, you have women who are grandmothers, they're in their 40s, they're grandmothers. You have a lot of young adolescents who are mothers, young children. A lot of the men are unemployed, they're not in the room. And when you screen the film, a lot of the mothers and grandmothers stood up and said, the issue is how do we talk to our own sons, because they're the ones in the gangs. So this is how do we start the community consultations and conversations for communities to take back their own neighborhoods. And the film was really motivating in the way, and it showed the agency of who are these health workers and why is this a community resource that we need to protect. It really showed the agency and humanities of the health workers, enabled those community level conversations, and it was also screened with the health department. And the health department has used it to influence, to invite the local politicians, to have the local premier come. They did a screening. It was something very motivating for the health workers as well to see. They did a gala event, a red carpet event, where the premier was invited, and it served as advocacy as well. So there are many ways in which these things can be used. I'm going to share with you two poems that highlight kind of what I'm trying to talk about in terms of the complexity of this context and what it means to be a health worker in this area. So the poems that were developed alongside the film, these are just excerpts. I was a machinist in a factory for 21 years, she tells me. There is no rain this morning. The sun is a simple yellow promise rising cold over the plains, streets, and homes. I volunteered for 7 long years. In that 7 years I was married, I had 2 kids. I had a full-time job, but I was always available for a shift. It's been 20 years since she first climbed into an ambulance. 20 years in service, and she has long since traded the safety and routine of the shop floor for the thrust of chest compressions and 12-hour road trips. Now she is a grandmother of 3, and treating children is the hardest part of the job. If a child gets hurt or ill-treated or mistreated, I forget what I am. I become a mother. If a kid gets knocked down, you want to bring them back. Outside, the winter is remembering how to bring back Cape Town's rain. It falls over the plain the same way it falls over the rest of the city. You can take what out of my scope, you can take away my vehicle, you can take away my uniform. But here, she points to her heart, here I'm a paramedic. We're talking about individuals who work in very difficult circumstances, but they're highly motivated and very proud of the work they do. The next poem is about a health worker and a paramedic who talked about how she first got involved. When she finished high school, she interned at a desk job, and then she also went along in an ambulance, and it changed her life entirely. The daughter, whose parents remind her to pray before she steps out on night shift, was 19 the first time she climbed into a van, 19 on a ride along and the first call. From the control room said gunshot wound. He was 19 and I was 19, she says. He died on the scene even though the paramedics did everything they could. That first call, up until today, it stayed with me. The daughter, who is also a sister, is treating a patient at their house the first time she is attacked. I got to the vehicle and there was a guy scratching through our things, and he put a gun on the seat. She throws her cell phone into the cubbyhole, turns around to see 4 men in front of her, their faces covered, their hands holding knives. The men search her and her partner, take everything. That was the first thing I was thinking about. Please don't rape me. It is years later, but each time she drives into Tafelsig, the palpitations return. She laughs. I laugh, but I know that is how I cope with things. She bakes, too, cakes and other things. She bakes more now than before. It helps more than the tablets do. The daughter, who is also sister, who is an aunt, hopes to be a mother someday. So I think these are things that the numbers don't capture. Not only the dedication, these are people who live in those communities. They need a police escort to go to to other areas, but they have no police escort when they go back to their own communities. They have multiple identities. And I think it's bringing out this human nature that really also, apart from the graphs showing the escalating violence that we've used to engage the local politicians to pay attention to this issue, and the community conversations that need to happen to develop local solutions to this problem.
Thank you so much. What an interesting presentation. Thank you so much, Asha. So we'll move on to our final presenter, Dr. Sasan Abdul Rahim. Dr. Abdul Rahim is an associate professor and chair in the Department of Health Promotion and Community Health at the Faculty of Health Sciences at the American University of Beirut. She teaches courses in health promotion theory, forced migration and health, and global public health. Dr. Abdul Rahim will be discussing early marriage among young refugee girls in Lebanon.
Okay, thank you very much. And thank you, Shaitali, very much for organizing this session to help us think about gender and to utilize some feminist frameworks to think about the work that we are doing. It's a pleasure to also present along with my colleague Faisal and with Usha George, whom I met for the first time today. So I'm presenting on behalf of colleagues. I'm in the Faculty of Health Sciences here at this university, and I've been working with a really great group of researchers on the issue of early marriage for the past 2.5 years, and we're hoping to continue to work on this issue and to develop our ideas and to make an impact with the populations, with the groups that we are working with. My co-PI is Dr. Jocelyn de Jong in the Faculty of Health Sciences, and we have a number of junior researchers who have been part of this research at different times. And we've also been mentored by Dr. Huda Zre, who's spent her life, a career, working on sexual and reproductive health. The title of my presentation is Education or Marriage, Gendered and Contextual Influences on Early Marriage Among Syrian Refugee Adolescents in Lebanon. We intentionally use the term early marriage and not child marriage because we see it as something that, a social phenomenon that is subjective in terms of, we see it as early marriage. The population, the group affected by it may not see it as such. The project that we have been working on since the summer of 2016 is called Project Amina. And its overall goal is to mitigate the drivers of early marriage among Syrian refugee adolescents in Lebanon, and through multiple approaches. I will show now the phases that we have been engaged in. But basically the two approaches that we are focusing on is basically educational retention. There's a very close link between girls' access to education and marriage, or early marriage specifically. And one of our approaches is really to work as much as possible to make it possible for girls to stay in school. And the other approach is to provide access to sexual and reproductive health information and services, both to girls who are already married, adolescent girls who are already married, and those who are not as well. An issue that is a little bit more difficult when we're talking about unmarried girls in our cultural context. So the context here, we're working in a displacement setting. We're working in a context of displacement, of course, where populations have experienced a sudden loss of livelihood, and where their children have lost, to a large extent, their access to education, and they experience a limited mobility and feelings of insecurity in a new settings. We also have think about the context before Syrians became refugees and displaced in Lebanon, where, as in many other countries in the region and around the world, there have been underlying gendered norms, unequal gendered norms that impact girls' and women's position in society and the decisions that, or their ability, their agency and their ability to exercise decision making. The other thing is, and which is something that's not addressed a lot in the literature, but there is data that shows this. There's been regional inequalities in women's access to education and health services in Syria before the crisis. And the populations that we are seeing that have become refugees in Lebanon are the populations that come from areas that have had much less access to both education and health services. So just very quickly, I thought I show this graph based on raw data from the latest national data available on Syria before 2011. And what this shows is that depending on where the woman lived, this is for girls/women between the age of 15 and 49 from the PAPFAM women's data. And basically, depending on the woman lived, that determined her access to whether she can have secondary education, whether she would have basic maternal and child health. So in some areas like Tartus, Latakia, and Suwaida, early marriage was low, but because access to secondary education was a little bit higher, not much higher than other regions in the country, and access to basic maternal health services such as weighing the baby at birth, which is an indication of having, delivering the baby in a facility, was much higher than other regions like Al-Hasaka, Deir ez-Zor, Raqqa, and Aleppo, where the access was lower. And early marriage in these regions was higher. The interesting thing is that in Damascus and rural Damascus, although women's access to secondary education was a little bit higher than in the peripheral regions, and access to health services was also higher, early marriage was also high in Damascus and rural Damascus. So anyways, going back to our work here among adolescent refugees in Lebanon, as I've mentioned, we've been working since the summer of 2016, and we've passed through a couple of phases, and we still have a couple of phases that we are anticipating and we're planning for. In the summer of 2016, we've conducted a prevalence study on early marriage in the Beqa, only in the Beqa area, with funding from UNFPA. Following, after we've analyzed some of the data that we had, we've decided that it's really important to move into doing some interventionist work on early marriage rather than continuing to do descriptive work. And with funding from the Ford Foundation, we've started an intervention that focused on school retention for 11 to 14-year-old girls. And we started a little bit in sort of like a shy manner. We wanted to focus on the population that is easiest to work with, and that was 11 to 14-year-old girls who are already enrolled in schools, because we felt we didn't know much about the context and how difficult work would be, and we wanted to try out by working with families whose daughters are enrolled in school. Of course, we acknowledge that they are probably girls who are more, in relatively speaking, more advantaged than girls who are outside school. And then with funding from the IDRC Canada, we've started an implementation research study to follow up on our work in schools. And here we're not only focusing on girls who are in school, but we're also engaging with girls who are not enrolled in school, and also with those who have already gotten married. And almost all of them would be out of school as well, based on some of the data we have. Our hope is really to transform this work into a longitudinal cohort study on adolescent girls in displacement settings, and to really study, to understand how these girls' lives are shaped and develop from early years of adolescence until young adulthood as well. So in the summer of 2016, there's been a lot of talk, a lot of NGO reports and meetings on child marriage and forced marriage and early marriage as one of the main problems among Syrian refugees in Lebanon and Jordan and Turkey as well. And we wanted to ask, first we wanted to ask the feminist question of, is early marriage really a problem? And then so not to take things at face value, but to inquire, and then if it is a problem, then what are its determinants? Why is it happening? So from our prevalence study, we found that 1 out of 4 girls between the age of 15 and 17, so 1/4 of Syrian adolescent girls were already married. In the study that we've done, our sample was 2,400 girls/women between the age of 9 and 24. And of those girls who are married, 60% have had at least one pregnancy. So from a health point of view, we saw that there is something that we really need to work on in terms of at least delaying pregnancy and not having marriage be a decision because of lack of opportunities for the girl. Early marriage, we found, was associated, and this is not surprising, with the mother's and father's level of education. So when the parents have less human capital, there's a much higher risk that the girl will get married early. And of course, the mother's age of marriage. And we actually tried to look into some displacement-related factors and how they influence when a girl gets married. It ended up being a little bit more complex. We're still looking at the data, even though we had the data for a couple of years now. So as I mentioned, the first phase of the intervention was school-focused. It was not school-based, but it was focused on girls who are enrolled in school. It was community-based, and we wanted to work with both the girls, 11 to 14-year-old girls, but also with their mothers and the fathers, because in many cases, it's not the decision, it's not the girl's decision to get married. I mean, the design was pre-test, post-test, one group design, and the intervention was based on interactive sessions with both the girls and the mothers and the fathers. Unfortunately, the part of the work with fathers didn't work very well. We weren't able to recruit fathers as much for the intervention, but the mothers were receptive. And the intervention content was delivered by 14 community workers who are Syrian women. We didn't have any community workers who are men. So the things that we looked at and we worked on in the intervention were the girls' attitudes toward education, gendered norms and attitudes, knowledge on puberty and menstruation, marriage, and also skills on decision-making and self-efficacy. I'm going to move into just showing some very basic descriptive findings from our work so far. The question that I asked at the beginning is, education or marriage? And what we are looking at right now is to try to look at in more nuance and more details about the parents and the girls and the parents' attitudes towards education and towards early marriage. And the message that is really clear in our results is that really things are nuanced, and we need to be really careful in how we understand the drivers of early marriage in this context. It is not only, I think it's unfair to think that early marriage is happening because parents do not care about their daughters or parents do not value education. What our results show is, in fact, I don't know, this is the, yeah. The results show that, in fact, both the girls, the mothers, and the fathers value education very much, and they value the education of girls as much as boys. So these bars show the girls, the mothers, and the fathers, and their level of agreement with the statement that it is important for girls to complete their education as it is for boys. However, when the question is posed in the manner that if the family has limited resources, is it okay that the family invest in the boys' education and not girls? The girls disagree with this. However, the mothers and fathers disagree with it a lot less compared to the girls. So it is an issue about limited resources. It's not an issue about, really just not wanting to educate the girl and not valuing the girl in the family. I'm just going to finish with this slide. Because it's, again, we're thinking about when do the girls and when do the parents accept marriage at an early age. And early marriage is defined as marrying before the age of 18. So when a question is posed specifically that if the girl is in school, she's less than 18 years of age and she is in school, then she should not accept any marriage proposals. What we find is that there's also high agreement with a statement like this. If the girl is in school and doing well, then neither the girls nor the parents agree with her getting married. However, when we ask the question in a general sense, and we say, if the girl, whether she's in school or not, receives a marriage proposal and the husband is suitable, is it okay that she accept this marriage proposal? The girls still disagree with this statement, but the mothers and fathers believe that if the husband is suitable, and it's not known whether the girl is in school or not, then maybe it's better for the girl to get married now because maybe later on, this is my interpretation, that later on she won't have a suitor who is a suitable husband, and for economic reasons, it would be better for the girl to accept now. So I just want to end by saying that now we're finalizing the first phase that focuses on school retention, and we're starting to work on the next phase where we will focus on providing information, or studying and providing information on sexual and reproductive health services, sexual and reproductive health information and services for adolescent girls. This is going to be a more challenging part of our work, and we'll consult with Faisal, of course. With you. We'll consult on his knowledge on the provision of these services to adolescents, particularly in a context where there's a belief that the girls don't know anything and have no idea what sexuality or marriage is until they get married, which from our experience is absolutely not accurate. Okay, thank you very much.
Thank you so much, Sausan. And thank you to all of our panelists. And I do want to leave time for each of you to ask them questions, and I realize we are running a little bit late. But if I may, I'm just going to ask them each a question to start. We started late. Yes. Youth-friendly services. Here we go. Okay. Okay. So, I mean, I think there are. I'm not going to try to summarize because we don't have time and because I wouldn't be able to. But it's interesting. We've heard from all three talks the idea of how we conceptualize things is very critical to how we think about innovations and how we think about interventions. Heard about differences in measurement and what's being measured, and obviously how you understand things is going to define that, and also voices and the importance of hearing different people's voices, different ways to hear their voices, different venues to hear their voices, different ways to people to engage. So I'm going to ask each of you one question. Faisal, you talked to us about youth-friendly services, as we know, and you talked about how there's not a framework really to assess this. You showed us some of the systematic reviews, and you also mentioned rights-based. So the question I'm going to ask you is, can you share with us any innovations you have in terms of how to measure a well-designed and a well-executed rights-based youth-friendly services facility?
Thank you very much. I was not threatening or anything, but I just want to have more time for people to ask questions. On the issue of rights-based framework, I think the answer lies very well with the recommendation of WHO and the issue of equity. Equity apparently is the most recurring theme in measuring the quality of service and the friendliness of service of the youth. And I think the whole question of equity is very much related to the diverse population and to the vulnerable population and to the disabled population. And that's why the whole issue also of universal health coverage also encompasses this issue of equity. What's really was striking for me, I think, to make things like really work is, besides equity, is creating demand in the community. Was also very much recurring in innovation or intervention in that regard, and engaging youth from the very beginning in the design and also in the implementation of the service.
You talked about a lot of things, but one of the things you talked about was the feminization of the human resources for health. So I'm going to ask you whether you've come across any kind of innovative financing models in the kind of, I know you didn't talk about this at all in your talk, and feel free to push back, but I was just thinking about, the whole values and the way workers are valued and paid, and whether there are some kind of innovations in financing and compensation that can be explored.
So I think there was the recent commission on the health workforce and economic development, making the case that, as Dr. Sukan presented, healthcare expenditure is increasing, and it can be seen as an engine for growth as well. And they're making the argument that investing in the health workforce can also lead to further gender equality because the workforce is so feminized. That will only happen. That will only happen if labor rights are addressed. I think at this point, yes, the workforce is highly feminized, but they're at the bottom end of the health workforce. So it's not enough to just, you need to put in, investing more in the health workforce doesn't necessarily mean, it's sort of, Dr. Suka said, how you spend the money matters. Not just adding more money, but really making sure it leads to better working environments, safer working environments. It's really been a call for a lot of amongst community health workers, the fact that we're not paying attention to gender-based violence in the health workforce it's a hidden agenda, making that come out. There are a lot of innovations, there's been some critical evaluation of performance-based financing, and has that led to improved health outcomes, better utilization, and health outputs? I think some of the lessons from that has come from performance-based financing is about changing how the whole health systems works. It's not just, these incentives are not just magic bullets. It hinges on many other things also being triggered. And when incentives are designed well, they lead to the whole team benefiting. They're not individual incentives. But there's been very little research on what are the gender dynamics involved. What's the composition of those teams? What kind of services are rewarded? And does that change the way are adolescent health-friendly services, are they part of that scheme or not? So I think we need more of a lens to actually look at these dynamics.
Sausan, the question I was going to ask you is about the engagement model that you've used in your study with young girls, and because we hear a lot about engaging people early, engaging different groups like parents and the youth themselves, religious leaders, etc. And you mentioned some interesting findings about how easy or hard it was to engage certain groups that you were targeting. Do you have any insight around innovations in designing these kinds of interventions that are meant to support and these youth in their health and well-being and in their futures? Who do you engage and how, and what's the right level?
Okay, thanks. So basically, we've implemented our the school retention intervention through community workers, Syrian women. Some of these Syrian women have teenage daughters, others are younger. And we've provided really rigorous training for these community workers to be able to implement the intervention with the girls and with the parents, with the mothers, specifically with the mothers. And the trainings were focused on gender, on other skills related to facilitating discussions with young girls, with adolescent girls. I have to say that we have to pay more attention to this in the future, because we felt that, currently we feel that the community workers need a little bit more training. I mean, the positive and the really important advantage for us is that the community workers are from the community and they are trusted, and they've developed a close relationship with the families of the girls as well. They're seen as a second, an older sister or an adult who takes care of their daughter. With the fathers, we have not been successful because we thought that the female community workers would have, and would be able to bring in the fathers for discussions and meetings related to their daughters. That didn't work out very well. So we are thinking about a different model of engaging the fathers right now. And it doesn't have to be through meetings. It might be through one-on-one exchanges. And I'm not sure if the only thing that needs to be done is just to have a male community worker. It might, we need to think about this in more complexity. Yeah.
Okay, thank you so much. I'm going to open it up to the audience, and maybe we'll take a single round because we are a little bit behind. So maybe we'll take 3 or 4 questions.
Do you want to pass the mic down?
Thank you. My question is to Dr. Alqaq. Was there any role for academic institutions and local NGOs in the, let's say, in the establishment and operation of the youth-friendly centers here in Lebanon? And how many, let's say, were planned to be established, and how many are still running and operating until now? This is one. And to Dr. Abdul Rahim, do you have any intention, let's say, of carrying out a controlled study among women in the community that are hosting the Syrian refugees to see if there is any comparison between the two groups?
Hi, also, Faisal, I think you said that you were with FIGO as well. Is there an official position from FIGO on the relationship between the school and the parents and their role in getting children? You mentioned demand generation, so getting young women into the services. What is the role of the school and the family in that?
Thank you for your wonderful presentations. I have a question perhaps for all the speakers. So are there any healthcare programs provided by the United Nations or NGOs that provide healthcare and human rights services for sex workers who are an extremely vulnerable population, especially in the Middle East where sexuality is a taboo? And if yes, have they been effective? Thank you.
Thank you. My question is addressed to all the speakers. How would you advise to tailoring interventions that are countercultural to the culture that you're intervening? And all the ethical considerations in that. And for Dr. Salsan, Dr. Abdul Rahim, are you looking into an intervention for the men that marry the girls?
And we'll take one more. I think there's somebody.
Thanks. I think firstly, very informative session. Took a lot from this. Thinking about gender and rights and interventions, just on family planning, I think there's a lot to be said about the role of politics. Some countries, probably Middle East, Africa, Tanzania, for example, they've banned family planning. The message by the president is to go forth and reproduce. So I think there's more work that needs to be done by partners and by religious leaders. But we spoke a lot about women, and what we're finding in sub-Saharan Africa is that women have a higher utilization to access services, and that men aren't accessing services. And I'm sure it's similar in the MENA regions where men have that bravado and they don't want to go to clinics and access services, and the attitude. So I don't know if you can just comment broadly about the situation here, men, how you get men to access the services. It's nice to hear a bit about how you engage sex workers, but just increasing the utilization by men and maybe even the role of religious leaders here. Thanks.
Okay, thank you very much. So I'm just going to open it up to whoever wants to respond to any of those questions. So maybe what we'll do is each panelist answer to the ones that you'd like to answer to, and then we'll close.
Yeah.
Oh, you have a mic.
Thank you, Ms. Thank you for all your questions. On the question of youth centers, there was several attempts, as you are aware, by UNFPA in collaboration with the Ministry of Public Health and Ministry of Social Affairs in Lebanon to start on youth-friendly services. But honestly, it was never really materialized into a service with impact and with a process that you can follow and you can build upon. And I can personally say we failed in doing this. We have another now trial that's going to happen again with the support of UNFPA and the Ministry of Public Health on starting a pilot of 3 to 5 centers that's supposedly to be youth-friendly centers. Outside the UN and the ministry, we have two NGOs that are providing services, sexual health services and consultations, mainly addressing the LGBT community. And in that regard, there was no measurement so far of the impact, but as I know, there is benefit and there is a good coverage for the needs of this specific community on the issue of centers. In the issue of FIGO, and any statement for the FIGO and the role of the school to engage, yeah. There is nothing clear on the school-based sexuality education statement from FIGO, but definitely there is a professional committee within the 11 committees of the FIGO on adolescent health. And that includes engaging, that includes sexual and reproductive health within health rights, and that also includes family planning. I can answer later on the sex worker. Oh, okay. Two NGOs in Lebanon are working on how to optimize sexual services for sex workers, how to train the providers and how to improve setting to make it accessible and friendly for sex workers to benefit from these services provided in that, I think, 3 or 4 specific centers. Thank you.
Thank you. So in terms of sex workers, there's some very important lessons from India, from sex workers who are unionized, and their own perspectives on what are the terms of services, what kind of services, both in Calcutta and Bombay, and there's a lot of documentation of that work. So if you're interested, those are 2 very good examples. In terms of supporting, I think we sometimes assume that health workers, they're often, the responsibility for changing culture is sometimes explicitly, sometimes inadvertently put on their shoulders. And the assumption is that because they are working in health, they will be able to do that as well, without really training and supporting them. What does it mean to challenge social norms? Particularly if you're a marginalized group as well. So as a community health worker, an A&M in India, she's often a woman who's moved to another village. Is she really going to be the person who's going to contest social norms of early marriage and caste and many other social hierarchies on her own? I think it requires much more thinking what it takes for health workers to become those social champions. And they can be, but we shouldn't assume that it happens naturally. They themselves come from those cultures and sometimes inadvertently or explicitly replicate social bias. And in that sense, we did a photo voice exercise in Uganda with community health workers. It's not enough to have a male community health worker. It's very important in terms of improving access to men because they feel much more comfortable talking about STDs, many things, if it's a male health worker. But that doesn't mean you're changing gender norms. And sometimes it's a missed opportunity. There's a lot more that could be done. It does improve access, but you still need to bring up the issues and develop an intervention to address gender norms.
Okay, in response to one question about involving the host community, I think, unfortunately, our project now is focused on displaced populations, but I think it's very important to engage with the host community in the future. Even if the fact that early marriage is much lower in Lebanon compared to Syria before the crisis and compared to Syrian refugees in Lebanon. However, our intervention is also about improving opportunities for girls and improving their capabilities and skills. So I think that also should be replicated in the host communities as well. About tailoring interventions that go counter to cultural beliefs, I think I will sort of repeat what has already been said, that I think it is important to challenge cultural norms that are harmful or that impede girls' opportunities or access to education and access to other resources in the family. However, it's also important to do this work in a way that doesn't stigmatize, particularly refugee populations, doesn't stigmatize them and stereotype them, and comes in with the attitude that, you know, we're coming in to change your culture, which is bad for you. I think one of the things we're really keen on is to understand how the context of limited resources is actually heightening the effect of these gendered norms that have been in existence for a long time, but it's making the situation even worse now.
Well, thank you very much. Please join me in giving our speakers a big round of applause. Thanks.